Hello friends, I am Dr. Harsh Mathur from Om Netralaya, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended. And in this interesting case, where this is a routine NS223, but the main challenge I faced was while cleaning up the epinuclear sheet, and at a point I felt I had caused some iatrogenic zonular dehiscence. But then let's see how things turned up. So by now the side ports have been created, phenocane injected, capsule stained, and after maintaining the chamber with OVD, a triplanar incision, barely nicking the limbal vessels, is created with the help of this 2.8 mm steel keratome. Now initiating capsulorhexis with the 26 gauge bent needle, and at this point the external red glow by Zine International has been switched on. No financial interest, but it enhances the contrast and we are able to identify the capsule with ease. So my aim is to create at least 5.25 to 5.5 mm of rhexis with the help of this Utrata forceps. It's a nice looking rhexis. Some OVD is burped out, going beneath the anterior capsule, lifting it up, gently injecting some BSS, going to the opposite pole and then pressing it, doing the same again. And after putting some OVD, let's dial the nucleus, the dialer, and the nucleus rotates nicely. Now with bevel down, this is Catrax 3 phaco machine. Some superficial cortex is removed, and in this case we will be doing a direct horizontal chop. So we'll be going in the subincisional area, burying the tip of the probe in the substance of the nucleus, going towards the center, and then this karate chopper goes to the far periphery, brought towards the probe and laterally separated, and we've got a good through and through crack. I'm trying to separate the other pole, and that's done. Now dealing with these two heminuclei, again holding this heminucleus in a deeper plane and then just chopping it off. So we have two pie-shaped quadrants and then one quadrant comes up. So now I've started emulsification. So now staying in the central safe zone, and most of the hard work is being done by the chopper, and in no time we are able to emulsify the nucleus. And that's it. Now the parameters are reduced and this nucleus is done. So now we have a thick epinuclear sheet. So now holding the cortex and the epinuclear sheet and pulling it. Now this is a sign of usually the bag being dragged along because the cortex doesn't come in such a huge bulk. So I became cautious, and now once I removed that part, I could see the anterior capsular rim. So that was a sign of relief, and then I went ahead with my aspiration. So always make sure you have a keen eye on the anterior capsular rim. You are not pulling it. So when you are just cleaning up the cortex, then usually it comes in small parts, but when you are dealing with the epinuclear sheet, it usually comes in huge chunks. So be careful while pulling it and keep an eye on the capsule so that you do not cause a iatrogenic zonular dialysis. So in this case, all is good. So now I'm injecting the IOL. It's a hydrophobic acrylic IOL. The leading haptic goes in the bag, and then the trailing haptic is gently dialed in. And that's it, it's gently nudged and it goes in the bag. So now we have a good overlap of the anterior capsule, promising a long term stability of the IOL. Now going behind the IOL, cleaning up the OVD nicely, and then hydrating the wounds, and the case is done. So the take home message is, while cleaning up the cortex, it usually comes out in small chunks, but when you are cleaning up the epinuclear sheet with the bimanual IA, keep an eye, it usually comes out in bulk, which may confuse you in that you have caused a zonular dialysis. But then keep a keen eye on the anterior capsular rim at the edge where you are pulling the epinuclear sheet. I hope you like this video. Do like and subscribe to my YouTube channel. Thanks for watching.